This conference will now be recorded.
All right, so we're going to talk about chapter 14 on shock. So as we know, shock is one of the more common issues that we deal with in the back of an ambulance. And I'm not saying like hemorrhagic shock, but more of a hypovolemic issues that we've had. So obviously non-external bleeding or just dehydration turning into shock. Septic shock as well, and sepsis being one of the more common ones. Just this week alone, I've already had 2 septic patients that have been very sick that we've had to transport in. So we're seeing this. We're seeing more of the sepsis because people are still not calling 911 until they're really, really sick. So let's get more into this here. So we're going to meet the national standard competencies in pathophysiology. All right. So remember that shock is a state of collapse and failure of the cardiovascular system. So really, it's an inadequate state of tissue perfusion. So in the early stages, right, the body attempts to maintain homeostasis. By doing this, it's the balance of all systems in the body. As shock progresses, blood circulation slows down and eventually ceases, going into cardiac arrest, right? So we're going to cover more about that in detail on looking at that compensated versus decompensated and irreversible shock. So shock can occur because of medical or traumatic events, right? So we have significant bleeds or internal, external to distributive shock like widespread vasodilation from sepsis to anaphylaxis, obstructive shock like cardiogenic or like a pericardial tamponade, things that can cause shock like that. So we need to be constantly alert to the signs and symptoms of shock and have an understanding of which ones are which, looking at signs and symptoms of like vital signs and patient presentation, along with looking at the mechanism of injury, if or nature of illness as well. So perfusion is circulation of blood within an organ or tissue in adequate amounts. We need to make sure our body's perfusing. This requires a working cardiovascular system. So the body is perfused by the circulatory system. There's 2 different circuits. There's a systemic circulation in the body and the pulmonary circulation in the lungs. With that, we have cardiac output, where the volume of the blood, the heart can pump per minute depends on myocardial contractility, preload and afterload. Okay, so we got to make sure we have good preload and good afterload as well to make sure that we have enough fluid to pump through the body, right? Now, are there certain circumstances where we have a reduction in preload? What can cause a reduction in preload? The heart has to be able to pump, and you have to have fluid going round and round, right? What would cause a reduction in preload?
CHF?
Say it again. I think I heard CHF.
Yeah, CHF.
Yeah, fluids, right? Around the heart, making sure it's not pumping effectively. That would be the myocardial contractility. A bleed, that could affect preload. What else?
Would it be some type of heart defect? So a
Okay.
primary AFib?
Yeah, it could. What about sepsis? Could sepsis affect preload? Any thoughts? Yeah, it can.
Sure.
Yeah, let's go with it, right? Because what does sepsis actually do? Bacteremia, causing widespread systemic vasodilation, therefore reducing the preload. So we have a patient having an MI, a heart attack, okay? They're hypertensive at 200 over 120. You give them aspirin. What else are we giving?
Nitro.
Nitro. What does nitro do?
Dilate.
Vasodilation, reducing
Preload.
preload. Imagine that, right? Perfect. Vasodilation, reducing preload. So if we have a patient who's having a right-sided MI, okay, your blood pressures are going to be low. So if you look at an EKG and you see on 2-3 AVF inferior wall of the heart, we're going to get into that later on in cardiology, and we see ST elevation. This patient needs fluids, not nitrates. Even if they have chest pain, we withhold nitro because they have a preload problem. There's not enough fluid coming in because they're already dilated enough and not producing enough fluid because that side of the heart, the inferior wall, is not functioning appropriately. Therefore, we need fluid to assist that preload versus giving someone nitrates to reduce it, causing the patient to basically bottom out their pressures. So there's a lot of different things that can affect that. And we can have afterload problems as well, especially if we have defects of the heart, like pericarditis, pericardial tamponade, and things like that. Perfect. So cardiac output. So let's talk about this. Blood pressure varies directly with cardiac output, systemic vascular resistance, which is SVR, and blood volume. So cardiac output is heart rate times stroke volume. Blood pressure is cardiac output times systemic vascular resistance. And then we look at our mean arterial pressure, which is generally considered the patient's blood pressure itself, that one specific number. So a MAP is a diastolic pressure plus 1/3 the pulse pressure, which is your systolic blood pressure and your diastolic blood pressure. Okay? Why is MAP important? Why is your MAP so important?
Be a good indication of what you have for pressure overall.
Well, it's your mean pressure between the two, right?
Mm-hmm.
So Matt's actually put a good point. Can it indicate sepsis? It can. That's how our body's perfusing, how well our body is perfusing. So we know where to go. Yeah, where are we going to go with this? We need to give them more fluids or not more fluids, right? So if we have a patient that has a MAP of less than 64, that is one of the indicators of severe or a systemic inflammatory response, right? That turns into a patient with a known infection or presumed infection site to become sepsis or septic. We want to get our MAP above 64, which therefore our blood pressure would probably be right around 90 over 52, 90 over 60. Okay, we look at that mean number. This number here truly represents how our body is really perfusing, and are we getting enough blood flow through the system to be able to prevent shock from happening. So that MAP is important. And now the thing is, we're taking a manual blood pressure, you'd have to go through and do the MAP for it. If you're using an auto BP cuff, that MAP will show up in parentheses on the cardiac monitor. Something at the EMT level that we really never talked a lot about, but moving in more into the advanced and paramedic stuff, that MAP is a big number for us because it helps us tell how a patient's actually perfusing or not. And like I said, less than 64, we're not perfusing appropriately. And if it continues to drop, that's when paramedics start getting involved and start giving pressors to bring the blood pressure back up. All right, so another role of the nervous system is the control of the cardiovascular system and a function of the autonomic nervous system. The autonomic nervous system is primarily regulated from the upper part of the medulla oblongata of the brain. So we have two parts of the autonomic nervous system, one being the sympathetic, which prepares the body for physical activity during a stressful situation, and the parasympathetic nervous system, which is primarily responsible for rest and regeneration while we're sleeping. So on the next slide here, it kind of shows you the physiology of that perfusion. So the figures show the sympathetic nervous system on the left. So this is your sympathetic nervous system. And this right here on the right is your parasympathetic nervous system kicking in. So with a sympathetic response, you're going to have dilated pupils, heart rate increases force of contraction, and also increased conduction speed. Your arteries start to constrict, your lungs, your bronchial muscles start to relax, and your GI tract starts to slow down. What medication can you give at the advanced EMT level that can stimulate the sympathetic nervous system? Epi. What else is a sympathomimetic?
Butyral.
Yeah, awesome. Yeah, albuterol. You're right. Exactly. Right? Now we have the parasympathetic nervous system. When it kicks in, your pupils constrict. Your arteries are no longer affected. Your lungs are no longer affected. Your GI increased salivation, increased motility. Your heart rate decreases. Right? Decreased contractility and depressed conduction speed. You start slowing the body back down. So as far as the advanced EMT level, going through the meds in my head, there's nothing that we have that's a parasympathetic system stimulant that stimulates that side of the world. So we have the regulation of blood flow. We have sphincters, which regulate blood flow through the capillary beds under the control of the autonomic nervous system, right? So the regulation of blood flow is determined by the cellular need and is accomplished by the vessel constriction or dilation. So if we get excited, so let's say Kobe is being chased by a tiger or a lion. I'm hoping his sympathetic nervous system would kick in, he'd start running away, or you turn around and shoot it. Right? So in that case, we would have increased blood flow, right? So going back to the slide, we'd have increased heart rate, increased force of contraction, increased conduction speed. Our heart rate starts to go up. Arteries are starting to constrict, pupils become dilated, and your bronchial muscles start to relax, and you start running away, or he's going to shoot the thing, one or the other. So that's kind of how that stuff works. When we're sleeping at night, our parasympathetic nervous system kicks in. So with this being said, regulation of blood flow is determined by the cellular need, again, and is accomplished by the vessel's constriction or dilation. And the maintenance of blood flow or perfusion is accomplished by the heart, blood vessels, and the blood working together. And the blood working together as one unit to be able to provide what we need. Now, with all that being said, we have to have respiration and oxygenation. Remember before, perfusion is measured by end tidal in the respiratory system, but again, oxygenation is measured by SpO2. So for each breath, the alveoli receive a supply of oxygen-rich air. Oxygen then passes through the alveolar wall into the pulmonary capillaries. If oxygenated blood is not properly circulated, then we have cellular death, right? So diffusion is a passive process in which molecules move from an area of higher concentration of molecules to an area of lower concentration. The oxygen molecules then move from the alveoli into the blood, so air comes in. The carbonic acid then breaks down in the lungs, and carbon dioxide is then exhaled, and this helps maintain the delicate balance between gases and also maintains proper pH of the body. So with our pH, what is our normal range?
7.3, 7.4.
Very close, 7.35 to 7.45. But no, good try. That was really close though. Awesome. Okay, so that's going to be our normal range we're looking for. We always run a little bit alkalotic. That's just the way our body functions with our pH, right? But if perfusion is off, can this deviate? Yeah, exactly, it can. And the best way to measure the deviation of pH is utilizing what tool? Other than a blood gas, which we can't do.
Capnography?
Capnography, exactly. So putting on waveform capnography and looking at these numbers, because we're going to see that change. A patient who is in shock is going to be tachycardic and they're going to be tachypnic. If they're tachypnic, what is their end tidal going to be? High or low? If they have a fast heart rate, would their end tidal be high or low?
It's going to be high.
Lower. Actually, it'd be lower. You have a lower number of end tidal. So fast respiratory rate actually decreases the amount of carbon dioxide being exhaled, therefore getting a lower number. Right? So if we have a person that's breathing slow, that's going to increase our capnography levels to like in the mid 50s to maybe lower 60s, right? And that's all going to be based on oxygenation. Are we perfusing appropriately? And can we fix that with oxygen and ventilation? Right? This is more of the perfusion of the respiratory and oxygenation cycle. So we can measure a lot of this stuff in the field, but taking what we look at for numbers, looking at our mechanism of injury or nature of illness that we have, based also looking at our visual and actual touching assessment of the patient, we should be able to come up with a decent treatment plan on how we're going to fix this patient, make sure they're oxygenated, perfused appropriately, whether it be through fluids, oxygen, or all of the above. So shock can be the result of inadequate cardiac output, decreased systemic vascular resistance, or the inability of red blood cells to deliver oxygen to the tissue. So is the heart failing? Do we have a bleed? So if shock state persists, it will ultimately result in death of the entire organism, right? The body is going to die. So we got to figure out why that's happening. Body attempts to compensate by shutting blood flow from the organs more tolerant of low flow, like the intestines, the skin, to vital organs like the brain, the heart, the lungs, etc. Now, what is the first organ to start shutting down in a patient who's in shock? What do you guys think it is?
Isn't it the stomach?
The stomach. So a patient who's in shock will start complaining of nausea. So what's one of the first things you think about doing? Giving them an antiemetic? Not really. We can think about Zofran, but what's really going to help relieve that nausea? Getting him out of that shock-like state.
Fluid?
Whether it be a patient who's hypoxic, putting him in the shock, to a patient who's in like a hypovolemic type deal, giving them fluids. What do we need to do other than just pumping meds into them? Can we give them simple stuff like fluids, oxygen? Or do they need to go to advanced level stuff if truly they are like a cardiovascular issue, like a cardiogenic shock? Do they need pressors in a paramedic level versus an A? So we'll talk more about that here in a second. But our body wants to keep the main portions alive, like the heart, the brain, the lungs, things that we need to survive, versus having your stomach functioning at this point in time, or just having peripheral oxygenation into the extremities. We start pulling from the extremity to the core. All right, so this picture here shows a cardiovascular system with 3 different parts. We have systemic circulation. As you can see, we have pulmonary circulation here. All right, moving into the heart. So as you can see, and kind of just to really break it down quickly, we have the heart, which is the pump, the set of pipes, which are the blood vessels or arteries that acts as a container. And we have the contents in the container, which is fluid or blood. Oxygen has to come in through the breath in, has to move its way through the lungs, right, into the alveoli, where carbonic acid breaks down the bad stuff, pushes out carbon dioxide out. Oxygen then attaches to the red blood cells and the hemoglobin, pumping through the body. As it's traveling through the capillary beds, it then oxygenates our system, perfusing our cells. Right? This is where we start talking about adequate tissue perfusion. If we have an inadequate state, if something is blocking it, whether it be any type of shock, right, that's when our vital signs start to change, and we need to provide immediate attention. So this is what they call the perfusion triangle. The heart, which is the pump function, which is damage to the heart, by disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. We have to have blood movement, right? Pericardial tamponade, myocardial infarction, I'm drawing a blank, pericarditis. These are all different things in the heart that can cause a dysfunction to make it so it doesn't pump appropriately. Blood vessel container function. If all the blood vessels dilate rapidly, the normal amount of blood volume is not enough to fill the system and provide adequate perfusion to the body. What can cause that? What can cause blood vessel container issues?
Medications?
It could, overdosing. What else? They got anaphylaxis.
Blood loss.
Yep. Well, we're talking about that one next, and the content function of blood. But the blood vessel changes, so vasodilation. So medications or like an overdose on like nitro or some kind of vasodilator. Trauma is going to be more of the blood issue versus a vessel issue, right? But you guys should be saying sepsis. Sepsis is a widespread vasodilation of distributive shock, just like anaphylaxis. That's why we give epinephrine to vasoconstrict to bring blood pressures back up again, right? Now we can talk about trauma, right? So blood content function. If there's enough blood, if there is enough blood or plasma loss, the volume of fluid in the container is not enough to support perfusion needed to the body. So that's our traumatic part of the stuff, right? Or if we have a patient that is, let's say, a gastroenteritis that is having excessive vomiting, excessive diarrhea, things like that will cause fluid loss, not vasodilation, right? Fluid loss. We have the heart pump function, the blood vessel container function, and the blood, which is the content function. And any deviation of any one of these can cause a patient to go into a shock-like state. So yes, Tondra, viruses as well can weaken your perfusion state as well, depending on the type of virus you have. So blood, remember, is a vehicle that is for carrying oxygen and nutrients throughout the body. Okay, it contains red blood cells, white blood cells, platelets, and plasma. Right. So blood clots control blood loss. We have to have plasma. We have to have platelets. We have to have stuff moving around and around in order to start forming that clotting process. Retention of blood. So blood clots control the blood loss. They form depending on retention of blood because of the blockage in the blood circulation. We have the change in a vessel wall, like a wound, or the blood's ability to clot as a result of a disease process or medication. What disease process would cause a patient not to clot?
Hemophilia?
Hemophilia. And so let's go one step more in depth. What factor are they losing to prevent that from clotting? You guys remember that one at all? So there's factor 5 and there's factor 8.
I think it's 5.
Okay. So factor 5, with that being said, was that, sorry, I won't interrupt you. I thought someone said something. Right. So we have to make sure we have factor 5. So patients that are hemophiliacs actually have a kit where they can inject this factor into them to help stop that blood from flowing out, prevent it, and promote clotting. I just lost my train of thought. What medications can inhibit blood clotting?
Aspirin?
That's correct.
All right, so aspirin is a platelet aggregator. So it doesn't really prevent clotting. It makes platelets less sticky to prevent any further clotting. TXA, Matt, actually promotes clotting. Lasix is for, there we go, Coumadin and warfarin, blood thinners. Lasix is a loop diuretic to help stimulate the ascending loop of the nephron. So we have Coumadin, warfarin, blood thinners. So what patients may you find on blood thinners? Yep, AFib. And what else?
Patients who just had heart surgery.
Yeah, patients had heart surgery. Patients had recent stents placed. They may be on Plavix. Yeah, TIA hits like stroke histories of PEs. Yeah, all this kind of stuff. So that's why it's so important, and that's why I hammered you guys on patient assessment, is getting a detailed history and doing in-depth touchy-feely assessments to be able to find everything and hear everything, because this information is all super important when talking to a patient to talk about or kind of how you're going to treat your patient moving forward. So when an injury occurs, platelets begin to aggregate at the site of the injury, okay? This causes red blood cells to become sticky and clump together. As red blood cells begin to clump, fibrogen reinforces the red blood cells. And then clots can become unstable and susceptible to rupture. Right? I just lost my train of thought. Where was I go with this? I'm sure it'll come back to me. I apologize. I completely lost it. Oh, aspirin. That's where I was going to go with it. Sorry about that. So when we give aspirin, those platelets that become sticky, it makes the platelets less sticky within the system. That's why they call it an antipyretic or a platelet aggregator, to make it less sticky to help prevent that clot from getting any bigger. So technically, aspirin doesn't thin the blood; it makes platelets less sticky. So the body's natural hormonal mechanism are triggered when the body senses that pressure in the system is starting to fall. So the sympathetic nervous system will then assume more control of the body's function during that shock state. And the parasympathetic nervous system controls involuntary function by sending signals to the cardiac, smooth, and glandular muscles and takes over during non-stressful situations. Also, a shifting of the body's fluids help maintain pressure within that system. So if a patient's going into shock and the sympathetic nervous system takes over, we start shifting fluid to where our body needs the most, and that's going to be in our core. So with that being said, compensation for the decreased perfusion, our baroreceptors then sense decreased blood pressure and flow and activate the vasomotor center in the medulla oblongata to increase that blood pressure. So our baroreceptors then take over. They say, okay, the blood pressure is starting to decrease, so now we need to increase that blood pressure, and how are we going to do that? We're going to increase heart rate. So our chemoreceptors then measure subtle shifts in the amount of carbon dioxide in arterial blood, and then stimulation occurs when the systolic blood pressure is between 60 and 80 in adults, or even lower in children. So our body starts to compensate, right? So now fluid's starting to shift. Our respiratory rate is going up to bring more oxygen based on the demand that we're losing. And because the demand is there, our heart rate then tends to increase, which in turn could either increase the blood pressure as well. Now, does all that change over time if it's not taken care of right away? Absolutely. Then we start going into our decompensated shock, and eventually turns into irreversible. So hypoperfusion, in a response to hypoperfusion, the renin-angiotensin aldosterone system in the kidneys is activated, and antidiuretic hormone is then released from the pituitary gland. So a result of this is an increase in the patient's blood pressure and maintenance of cardiac output. So the overall response to the initial compensatory mechanism is to increase the preload, the stroke volume, and the pulse rate, which usually results in an increase in cardiac output. All right, so autotransfusion effect then starts kicking in, along with the subtle effects of other response systems of the body, which then allows to compensate adequately for a volume loss of up to 25%. Once we start going above that, our body can no longer help maintain, and we start seeing more hypoperfusion. If that happens, the myocardial function starts to worsen with a decreased cardiac output and ejection fraction. Right? The tissue perfusion decreases. The fluid may leak from the blood vessels, causing systemic pulmonary edema. As a result, for this, as the patient decompensates, perfusion to the brain and coronary arteries start to decrease, and then cells will switch from an aerobic to an anaerobic metabolism. Remember, the anaerobic metabolism is a cellular process which occurs in the absence of oxygen, right? And the aerobic metabolism is all cell processes occur with an adequate oxygen supply. So we have an anaerobic metabolism that starts taking over because now we're losing the oxygen because we're hypoperfused. And the body then will produce epinephrine and norepinephrine in the adrenal glands in a response to hypoperfusion, right? So what is the neurotransmitter of the sympathetic nervous system? So what would be the neurotransmitter of the sympathetic nervous system? Right, epi. So epinephrine and norepinephrine. So the neurotransmitter for the parasympathetic is acetylcholine, right? So our body is then producing epi and norepi to then help maintain that by increasing our heart rates and vasoconstricting and shunting blood to the core. All this stuff is happening inside the body. So planned shunting of the blood, which I just mentioned, from areas of lesser need to areas of greater need is referred to as the pecking order. I'm not talking about chickens, okay? So the pecking order, okay? This is the golden hour, the golden period. We talked about the golden hour in trauma, the platinum 10 and the golden hour. So failure of compensatory mechanisms to preserve perfusion results in decrease in preload and cardiac output. Therefore, we're going to start seeing hypotension, right? Now we're starting to go into our decompensated shock. Is all this stuff making sense? Everybody good? Okay.
Hey, Kevin. Sorry I'm late.
No worries, man. All right, so shock-related events and capillary microcirculatory levels. So as perfusion decreases, cellular ischemia occurs, right? With that, it can quickly result in a metabolic acidosis. So let's go back to acid base. What is off and a patient has a metabolic issue? What would you see a change? A change in? Acid-base balance is based off three things, right? pH, carbon dioxide, so N-tidal, and what else? Yep, bicarb. So our bicarb normal value, right, is what? (22 to 26). Perfect. Good job, Kenny. So this can quickly result in a metabolic acidosis. So we're going to have a low pH with a change in metabolic or a change in our bicarb. So the regulation of blood flow is accomplished by vessel constriction or dilation, working in tandem with a sphincter constriction or dilation. In turn, the anaerobic metabolism results in a systemic acidosis and depletion of the body's normally high energy reserve. Incomplete glucose breakdown results in an accumulation of pyruvic acid. Ischemia then stimulates the increased carbon dioxide production by the tissues. Then they become acidotic. So acidosis then serves as an indirect measure of tissue perfusion, which reduces the levels of ATP, adenosine triphosphate, result in a dysfunctional sodium-potassium pump. So what does all that actually mean? What does all that actually mean? So taking everything that's all here, the reduction of ATP resulting in a dysfunctional sodium-potassium pump, acidosis then kicks in, right? Our body's not perfusing. We have a dysfunctional sodium-potassium pump. There you go. Our heart's no longer pumping. We are going to decompensated shock. Exactly. Right? Our sodium-potassium pump runs our electrical conduction system. It controls our heart rate. It controls the pumping of our heart. If our sodium-potassium are not serving on homeostasis level, okay, we're going to start having arrhythmias. We're going to start seeing decrease in heart rates. We're going to start seeing decrease in blood pressure. Our pump cannot effectively work without having electrical conduction, which we need the sodium, potassium, magnesium, all the different electrolytes to help function. Right, so we start seeing that decrease. Right, so the cellular flooding, which then explodes the lysomal membrane and releases lysomal enzymes within the system. Remember that lysomes or lysomal enzymes are destructive cells, so they auto-digest the cell, leading to organ failure. So lysomes they're kind of like on the fire from like a truck company going in and destroying everything. If you look at the fire service, so that's what they're there for. There are lysomal membranes and lysomal enzymes get released to auto-digest the cell as a destructive part of the cell. Reduction of blood supply to vasomotor center in the brain results in the slowing and stopping of sympathetic nervous system activity. Continuing buildup of lactic acid and carbon dioxide acts as a potent vasodilator, therefore causing widespread vasodilation. In conjunction with all of this injury occurring, the white blood cells and blood clotting system now become impaired. Right? If that happens, we start seeing disseminated intravascular coagulation can occur, which is called DIC. And DIC has also been found to complicate septic shock. So breaking down sepsis really quick, right, and multiple organ dysfunction syndrome, we have a patient that has severe inflammatory response. Okay, we find that with a known or presumed infection site turns into sepsis, right? With treatment of fluids with no change in blood pressures becomes severe sepsis. Once we get into a pressor, it becomes septic shock. Patient then will most likely be intubated because we got to maintain their oxygenation. They're going to put on pressors to help vasoconstrict to bring up the blood pressure and the heart rate in hopes that will work. Okay, with that happening, the patient can go into multiple organ dysfunction syndrome, and on top of that, develop DIC, where you start having a widespread clotting party, basically causing the end-all be-all of DIC is the point where we start shutting down vessels in the extremities, and people can actually start losing limbs. Right? So this all can be caused by a simple paper cut that turns septic or pneumonia. That's why it's so important to pick up sepsis in the field so quickly to start fluid replenishment and treatment, right? So multiple organ dysfunction syndrome, or MODS, is a progressive condition characterized by a combined failure of several organs. The major cause of death following septic, traumatic, and burn injuries is MODS. So this occurs when an injury or infection, as in septic shock, triggers a massive systemic immune, inflammatory, and coagulation response, resulting in the release of mediators and activation of the complement system, the coagulation system, and the kallikrein-kinin system, which typically develops within hours or to days following resuscitation, right? So we start resuscitating these patients. I'm not talking about cardiac arrest resuscitation, but resuscitating them with fluid resuscitation, pressors, right, and everything else. This is why these patients get intubated. This is why these patients get Foley catheters put in place, so we can measure how much fluid is coming out through the Foley catheters. Should be 30 mLs an hour on average, right? So are we seeing that? Are their kidneys shutting down? Right. So we look at all this stuff, and sepsis is a killer. I mean, no joke. Patients wait too long, and then they're so sick. This is what it turns into: is MODS, things like that we were just talking about. So we got to pick up early on the simple indicators of shock, and start our treatments early, and they'll have hopefully have a better outcome later on. Right. So other signs and symptoms of MODS would be hypotension, insufficient tissue perfusion, uncontrollable bleeding, multi-system organ failure caused mainly by hypoxia, tissue acidosis, or severe local alterations of metabolism. As far as respiratory impairment goes, insufficient concentration of oxygen in the blood can produce shock as rapidly as vascular causes. Without oxygen, organs in the body cannot survive, right? We have to have 3 things for the body to stay alive, right? What were they? Sugar, oxygen, and blood. Without those 3, the body can't perfuse and live. So certain types of poisoning may also affect the ability of the cells to metabolize or carry oxygen, like cyanide poisoning or carbon monoxide poisoning. In anemic patients, or anemia is defined as an abnormally low number of red blood cells, right? So this may be the result of either a chronic or an acute bleed, or if severe, tissues may become hypoxic. The only way to tell if a person has low red blood cells is getting a CBC done at the hospital. That's why it's so important, if your service and your system allows you to draw labs, draw them, because they can send them off pretty quickly, and a CBC usually takes about 15 minutes to come back. They can tell if a patient has low white count or elevated white count, red count, and then your hematocrit and hemoglobin counts as well, to see if they truly do need blood. Other causes of shock would be bleeding, respiratory failure, acute allergic reactions, and overwhelming infection. So let's actually get into the shock itself. We already talked about the vessel, fluid, and pump failure on the shock triangle, right? So let's actually get into the causes of shock. So expect shock if a patient has multiple severe fractures, okay, abdominal or a chest injury, spinal injury, severe infection, major heart attacks, and anaphylaxis. Let's go over those a little more. Shock may be the result of a variety of different causes. Hypovolemia from blood or fluid loss is a common culprit, right? So diarrhea, vomiting, bleeding, things like that. So table 14.4 in your books also explain the differences between the types of non-hypovolemic shock and how to differentiate them from hypovolemic shock. Hypovolemic shock is shock due to inadequate blood volume. Hemorrhagic and non-hemorrhagic causes of hypovolemic shock, okay, one or the other. Non-hemorrhagic shock occurs when the fluid loss is contained within the body. All right, so those are the differences between the two. Abnormal losses of fluids and electrolytes, like dehydration, may also occur, right? So gastrointestinal loss, especially through vomiting and diarrhea, increased loss of result of a fever, hyperventilation, or high environmental temperatures through the lungs. So we start seeing hyperventilation. We're actually losing fluid as we breathe. Okay, and increased excessive sweating. Internal losses, third space lossing, like in a peritonitis or a pancreatitis and the ileus. So we start getting third space fluid. Plasma loss from burns, drains, or granulating wounds. Other causes include ascites, diabetes insipidus, osmotic diuresis secondary to hyperosmolar states. Okay. When would you find a patient in a hyperosmotic state? Hyperosmotic non-ketonic state. When would you find that? Yes, not just high blood glucose, but very high blood glucose. These are patients that have glucoses that are like 600, 700, 800 that have gone past that diabetic ketoacidosis state. And most of the time, these patients are unconscious. And that's what they call the hyperosmotic non-ketonic, or they call HHNC, coma. So they'll be unresponsive for these patients here. These patients are usually put on insulin drips and massive amounts of fluid, right? So you may have that as well, the whole diabetic part. Good. So things are starting to come together a little bit more. I like it. So the earliest signs of shock are restlessness and anxiety. If alert, the patient may report of being thirsty. The patient may feel nauseated and even vomit. The skin becomes pale, cold, clammy, sometimes even mottled. We'll start seeing our heart speed up, right? So our heart's going up now for shock, right? Because we're trying to, in turn, move those red blood cells around faster with oxygen. Symptoms of dehydration include loss of appetite, nausea, vomiting, and sometimes fainting when standing up, or they call postural syncope. The best way to test for this is doing what specific test? What do we want to check for on these patients that have potential for dehydration? Yeah, orthostatics, awesome, good job. So lying down, sitting up, standing up in 2-minute intervals, right? As bleeding or fluid loss continues, the blood pressure finally falls into in the shock patient. Do not wait until the blood pressure falls before you suspect shock and begin treatment. By this point, we're in almost decompensated. We're getting to that point now. The goal in treating shock is to save the brain, the lungs, and the kidneys. So the best indication of brain perfusion is the patient's level of consciousness. If they become altered, we need to start treating more aggressively. So a patient that is in shock, right, and has electrolyte imbalances, what medication can we give them to assist with that? Ringers. Yeah, exactly. LR. I think LR is a phenomenal medication, but it has to be given in the right circumstance. Okay. So you have to understand what you're treating before you give it. Cause and effect. So cardiogenic shock is caused by inadequate function of the heart, so pump failure. Edema, which is present of abnormally large amounts of fluid between the cells in the body tissue. Heart failure, right? Pulmonary edema results in impaired ventilation. So for blood to circulate efficiently, there must be a right amount of pressure and adequate number of heartbeats. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. As afterload increases, the cardiac output decreases, which may result in low cardiac output due to high afterload, low preload, and poor contractility, or any combination of the three. If that happens, where does the fluid end up? In the lungs, right? So how are we going to treat that? What is our treatment for this? Okay, CPAP if the blood pressures are within normal range or higher, hypertensive or normotensive patient. If they're hypotensive, we cannot use CPAP though. Okay, that's contraindicated, right? But normally in a patient that's in like acute pulmonary edema will be hypertensive, but if they're in cardiogenic shock, that blood pressure is going to fail, so we got to be careful. Okay, but if they are hypertensive, another medication we can give is nitrates. If they're hypertensive, right, to make that container bigger. But if they're in cardiogenic shock, most likely they're going to have very low blood pressure and they're going to need to be on pressor. And CPAP or BiPAP, if there's fluid in the lungs, may be an option. All right, awesome. Obstructive shock results when a condition that causes mechanical obstruction of the cardiac muscle also affects pump function. So cardiac tamponade occurs when the blood leaks into the pericardium. What is the name of the triad for cardiac tamponade?
Beck's triad.
Beck's triad. And how can we look for Beck's triad? What are the three things we look for in Beck's?
Is it JVD one of them?
JVD is one of them. Yeah, you got one. Got two more to go. Yeah, muffled heart tones.
And narrowing pulse pressures, isn't that right?
Narrowing pulse pressures, right? Not widening, narrowing. So our blood pressure, systolic versus diastolic, will be very, very close in numbers, like 80 over 76. You know, close numbers like that. That's our narrowing pulse pressure. Okay. So we're looking for those three things. If we see those three things, it's pericardial tamponade. What is the treatment for pericardial tamponade? Drive fast, right? The hospital. Exactly. A big needle, a big long needle. It's called a pericardial centesis. Pericardial centesis. Something that has usually done with guided ultrasound going in. However, nothing that we're going to do in the field. So these patients need a surgical intervention of some sort to relieve that fluid. So tension pneumothorax can also be caused by damage of the lung tissue as well, or to the lung tissue. So obviously a collapsed lung. The heart and respiratory rates increase and become shallower, and the blood pressure starts to decrease. Remember that tracheal deviation is a very late sign of tension pneumothorax. So if you see it, they've been in it for a while. Pulmonary embolus, or a blood clot that occurs in the pulmonary circulation, can prevent blood from being pumped from the right side of the heart to the left. Right? Patients die from these things. They need surgical intervention. There's nothing we can do in the field. They need to get to a hospital. They got to get on heparin to thin the blood, and then hopes will be enough time to get them to a surgical site where they can go in and pull the clot out. Distributive shock results when there is widespread dilation of the small arterioles and small venules, or both. So septic shock, and we're going to cover a lot more in sepsis later, occurs as a result of severe infections, usually bacterial toxins. Usually bacterial, where toxins damage the vessel walls, causing increased cellular permeability. So now we have widespread vasodilation, we have increased cellular movement, which presents similarly to hemorrhagic shock. You'll have the weak, thready pulse, shallow, rapid respirations, altered mental status, and warm or hot skin. Can a patient be hypothermic with sepsis?
Yes.
Yes. Is that bad?
Very bad.
Very bad, because our body can no longer regulate temperature. Right? We've lost that ability of our thermoregulators to regulate body temp. Right? Therefore, the patient becomes very hypothermic. Cold sepsis is worse than warm sepsis. Sepsis is bad altogether. Right? We don't want to have our, as you can see, the dilated vessel here. Think of that dilated vessel, but through the entire body. Right? Widespread vasodilation, and then turn into DIC and MODS. The patient can die. They will die from this stuff if not treated effectively with broad spectrum, and well, actually more, not broad spectrum, but more high-powered antibiotics to stop that infection, and also finding out where that infection truly is. Whether it be a urosepsis from UTI to septic pneumonia, or a traumatic injury that caused sepsis itself from an infection there. Neurogenic shock is a result due to damage of the nervous system that controls the size and muscular tone of the body's vessels. Muscles in the walls of the blood vessels are cut off from the sympathetic nervous system and nerve impulses that cause them to contract, right? So all vessels below the level of the spinal injury will dilate widely, increasing the size of the capacity of the vascular system. What you'll see for characteristic signs will be absence of sweating below the level of injury, normal warm skin, and a lack of an elevated pulse. Right, something very important to pick up on. Anaphylactic shock, which should be a review for a lot of us, occurs when people react violently to a substance to which they have been sensitized. Right, so there is no loss of blood, there is no mechanical vascular damage, and the only slight possibility of direct cardiac muscular injury. So this results in a widespread vasodilation, increased permeability, and bronchoconstriction. In instances that cause severe allergic reaction would be injections, stings, ingestions, inhalations, all these things here, which can develop within minutes or even seconds after contact with a substance to which the patient is allergic to. Right? So cyanosis is a late sign of anaphylactic shock, right? So we want to make sure we catch it early. And then we have psychogenic shock, where the patient has a sudden reaction of the nervous system that produces a temporary generalized vascular dilation, resulting in fainting or syncope. Causes of syncope that are potentially threatening result from the events such as an irregular heartbeat or a brain aneurysm. Right? We can treat the anaphylactic stuff in the field with epinephrine. Remember, though, be ready for a second dose. Good questions to be asking, too. Have you ever been intubated for this before? If they say yes, then you might want to have a paramedic coming anyways, because that may have to happen, especially if they have significant airway swelling. Also look for angioedema, which is swelling of the tongue, and widespread urticaria. Is it a local reaction or is it widespread? Checking vital signs as well, looking at pupillary response, and then also asking the patient questions. But epinephrine, don't be afraid to give it, okay? Intramuscular 0.3 milligrams for the adults, right? In the right or left lateral thigh. So the progression of shock, so shock occurs in two successive stages, compensated and decompensated. So compensated shock is an early stage of shock, while the body can still compensate for blood loss. Decompensated is a late stage when the blood pressure now starts to fall. Irreversible shock is shock that has progressed to a terminal stage, which means they're going to die. They can't be reversed at that point. Right. So when we're in compensated shock, so at this stage, the level of responsiveness is a better indicator of the tissue perfusion than most other vital signs. The chemical mediators then are released by the autonomic nervous system, which then increases the rate and depth of respirations. The blood pressure is maintained, but there is a narrowing of the pulse pressures. You got to look at those blood pressures getting close together. The pulse pressure being the systolic and diastolic pressure. Patients that have had a positive orthostatic vital sign or may have that, and treatment at this stage usually results in a full recovery. So we want to make sure we catch it in the compensated shock. Decompensated shock is when the blood pressure starts to fall, or blood volume then decreases more than 30%. Remember, the body can maintain up to 25%, and any more than that, you're looking at decompensated shock. Compensatory mechanisms begin to fail, and signs and symptoms are much more obvious at this point. Cardiac output starts to fall dramatically, and vasoconstriction then can have a disastrous effect if allowed to continue. So treatment at this stage will sometimes result in recovery. Irreversible shock is where the arterial blood pressure now is abnormally low. A rapid deterioration of the cardiovascular system occurs that cannot be reversed. life-threatening reduction in cardiac output, blood pressure, and tissue perfusion. The distinction between the decompensated and irreversible shock is made on the failure of the shock state to reverse with an appropriate treatment. So we give all these fluids and pressors and it just doesn't fix it. Now we're in the irreversible state, which is not possible to distinguish irreversible shock from severe decompensated shock in a pre-hospital environment. They need to be tested, okay, through lab work and everything else, like rising lactic levels to other stuff they're going to get through blood work as well. So looking at the patient assessment, looking at a scene size up, obviously be alert to hazards. Once you're on scene, look to address hazards and threats to the safety of the crew members, bystanders, and the patient. Remember, gloves and eye protection at minimum. We're going to put several pairs of gloves in your pocket for easy access, right? In case it's a traumatic event, you get blood all over the place, or vomit, poop, whatever needs to happen, feces. Several pairs of gloves. Observe the scene and the patient, looking for clues, right? Everything we covered the other on Sunday. The more traumatic the injury the patient has sustained, the less likely the patient is able to compensate. So we got to pick up on these injuries in our rapid trauma assessment, right? We're going to do our primary survey, doing a rapid body scan and determine LOC. We're going to identify life threats and manage them to our best ability, determine priority of the patient, sick or not sick. Treat the threats to the circulation, airway, or breathing are considered life-threatening and must be treated immediately. We'll look at life-threatening bleeding should be treated first. So if there's a bleed, you stop it. We're going to quickly assess the airway, ensure it's patent. Be alert for abnormal sounds such as gurgling or stridor. Quickly assess patient's breathing. Observe the patient's signs of accessory muscle use, tripoding, nasal flaring, things like that. Increased respiratory rate is often an early sign of impending shock, so look for tachypnea. We're going to assess the patient's circulatory status by checking the presence of a distal pulse. A rapid pulse usually suggests a compensated shock. To maintain a high index of suspicion as well. If the patient shows signs of hypoperfusion, we want to gain IV access and treat aggressively and provide rapid transport. Patients that are in shock, try to get 2 lines in place. All right, administer fluids en route, whether it be ringers or saline, one or the other. Just give them some fluids. Do not delay transport to complete non-life-threatening treatments. Right. History taking, chief complaint, sample history. And one of the things you want to make sure you look for is blood thinners. So ask the patient, are you on blood thinners? As far as your secondary assessment goes, repeat the primary survey. Start with your full body exam. This one here, remember, is more detailed. And make sure that you identified all the injuries. Obviously, your life threats should already be treated, but reassess the treatments you've done on the life-threatening injuries to make sure that they're still holding and maintaining appropriately. 5 minutes for unstable, 15 minutes for stable patients, and using monitoring devices, including cardiac monitoring, pulse oximetry, and capnography. Before using the non-invasive blood pressures, you really should take a manual pressure first to kind of see where you're at. You also want to make sure that you monitor blood glucose levels as well. As far as your reassessment goes, determine if the interventions performed are having any effect. So you have to reassess your patient. Determine the interventions needed for your patient at this time and at this point, and based on the findings that you have, we're going to focus on supporting the cardiovascular system. Treating for shock early and aggressively will help prevent inadequate perfusion from harming your patient. So again, you have to pick up on those signs: tachypnea, hypotension, tachycardia, altered mental status, cyanosis, pale skin. Pick up on those different signs that are there and try to address them. As far as emergency medical care for shock, we're going to control obvious external bleeding. We're going to place the patient in a position dictated by local protocol. We're going to make sure the patient stays warm, so heat blankets, hot, warm fluids, gain IV access, prevent body heat loss. Be careful not to warm the body too much, though, but just enough. And do not use external heat sources such as hot water bottles or heating pads. They do make heat blankets that you can utilize for patients that are hypothermic. Those are perfectly fine in the EMS setting. Remember that the golden hour is the first 60 minutes after the injury. And one thing they don't mention is something called the Platinum 10. And that's the first 10 minutes of when you arrive on scene, you should be transporting the patient. Right? And the patient starts saying that they're very thirsty, that usually accompanies shock. So give the patient a moistened piece of gauze to chew on or suck on. Again, we don't have much. If you have water bottles in there, there's nothing wrong with them kind of keeping their mouth moist. You can do that if you'd like. I mean, I wouldn't recommend giving them saline to suck on. That's just horrible. So initial shock management would be manage the airway, administer supplemental oxygen, position of comfort, vital signs, reassessing vital signs, obtaining IVIO access for medication or a fluid bolus, and maintain body heat. Remember, critical patients, 2 attempts, 90 seconds, drill. So IV therapy, IV lines are inserted to provide a route for immediate replacement of fluids, a route for potential replacement in a patient who are at risk of losing substantial volumes, or a route for medications. If the patient is hypovolemic, shock needs IV fluid replenishment. So in case of the need for emergency administration of meds, IV lines should also be inserted just to keep open. Most protocols advise administration of fluid boluses at 20 to 30 mLs per kilo and 250 ml increments until radial pulses return. 20 ml is for pediatric, 30 ml is for adults. If vital signs return within normal limits or reach the desired status, reduce IV fluid administration at TKO rate and reassess frequently. And then paramedic intervention to administer vasopressors if needed. So if your blood pressures are not being fixed by fluids and the patient keeps deteriorating, that's when you want to get a paramedic on board to go with a vasopressor instead. Special considerations, remember for instances where increasing blood pressures may be detrimental to the patient, right? Only administer enough fluid to maintain radial pulses. So right around a systolic blood pressure of 90 to 100. Our goal is not to get them to 150 systolic. That is not our goal. Enough so we can perfuse the body. Aggressive fluid therapy increases the workload of the heart, worsening cardiogenic shock and increasing internal bleeding. So the more fluid we give, the more bleeding is pushed out, whether it be internal or external. So maintain that homeostasis. And by doing so, it's right around 90 to 100 systolic for a blood pressure, and make sure that your MAP is above 64. Temperature control is also vital in maintaining perfusion in children and infants, and you can utilize a Broslo tape to help with that. Infuse a 20 ml per kilo bolus of warmed isotonic crystalloid solution, considering a second infusion if there is no response to the first. You're going to carefully monitor the patient's status and treat conservatively an instance of uncontrolled hemorrhage. Patients who have chronic hypertension may require a higher blood pressure to achieve the same level of end organ perfusion. So that's why it's so important to get your sample history. So the only way to maintain a fetal perfusion is to aggressively treat the woman. So place pregnant patients on the left lateral recumbent side as well. As far as assessment goes in treating hypovolemic shock, control all obvious external bleeding en route to the ED. Establish at least one 18-gauge peripheral line using an over-the-needle catheter. Recognize the internal bleeding and provide aggressive general support. Secure and maintain the airway. Do not give the patient anything by mouth at this point. Monitor the patient's mental status, pulse rate, blood pressures, SpO2, and if required, end tidal. Patients that are bleeding out, patients that have any form of potential shock, should have end tidal running. Okay, it helps you monitor their perfusion status, right? And then transport to the most appropriate closest facility. When treating for cardiogenic shock, we're just going to finish up this chapter. We're almost done. Before administering nitroglycerin, be sure the systolic blood pressure is greater than 90 and consult medical control. Look at your local protocols, Maine, New Hampshire, Massachusetts, whatever it may be, all right, before you start giving nitro. Assess the patient's blood pressure and gain IV access prior to nitroglycerin administration. Remember, nitro vasodilates. You may have to give more fluid to control that. Place the patient in a position of comfort, give them high flow oxygen, provide prompt transport to the emergency department and gain IV access, and frequently check a pulse if the patient is an unresponsive patient to find out if the patient needs an AED. Again, put them on a cardiac monitor. We can watch their pulse rates and everything else too, as well. For obstructive shock, for cardiac tamponade, is basically high flow oxygen. Remember, this is a high priority patient. Weight the need for positive pressure ventilation and possibility of decreased venous return to the chest. Only definitive treatment is surgery or pericardiocentesis. So only treatment available to pre-hospital providers is early recognition, rapid transport, definitive care. Tension pneumothorax, paramedic because they need a needle decompression done. So gain IV access, give them high flow oxygen non-rebreather for patients to prevent early prevention of hypoxia. A pulmonary embolus, we're going to assess the blood pressure, provide a fluid bolus of 250 mLs of a crystalloid solution, recheck the blood pressure after. Patients may breathe more comfortably in an upright or partially upright position. Please do not lay patients down that you suspect a PE in. Definitive treatment involves anticoagulation to prevent progression, ventilatory and circulatory support, and occasional thrombolytic therapy, or they might have clot retrieval done, surgical intervention, which is not possible in the pre-hospital setting. Another thing you also want to do as well with this is put a patient with a possible PE, right, on end tidal. A patient that has a PE or potential for a PE, potential pulmonary embolus, will have a normal end tidal reading and then a significant drop in end tidal down to, like, let's say 35 to 45 down to like 18. Right, so that's something else you want to pay attention to. Treating for sepsis. Septic shock requires a complex hospital management, including antibiotics as well. But this all starts in the pre-hospital field by giving fluids. That's where it really starts. So high flow oxygen, IV access. If you can get 2 lines in place, even better. And standard precautions. Remember that they are infected and not sure what it could potentially be from. And fluid administration. For neurogenic shock, best treated in a combination of all known supportive measures. So emergency treatment must be directed at obtaining and maintaining proper airway, providing spinal motion restriction, assisting inadequate breathing as needed, conserving body heat, and providing the most effective circulation possible and transport promptly. All right, treating anaphylaxis. Obviously, being aware of what's going on. Sensitivity may be, they may carry a bee sting kit containing epinephrine. If they do, they need to have epinephrine administered. If you get called to a patient who's given epinephrine, again, you may have to give a second dose, third dose, or fourth dose, depending on your transport. These are patients that we should not be signing off. And if they do not want to go to the hospital, we need to be contacting med control because the epinephrine is temporary. It can wear off. What they really need is a histamine blocker like Benadryl, right? They actually stop that progression, right? You want to make sure if you're transporting, you also gain IV access. And as far as treating psychogenic shock, it can substantially worsen other types of shock that are there. So record your initial observations of the vital signs and the level of consciousness. And try to learn from the bystanders whether the patient reported any problems before fainting or how long the patient was unresponsive for. All right, with that being said, let's see, it's 8:20 now. Why don't we come back at 8:40? We'll take 20 minutes. Come back at 8:40, we'll finish up the last chapter. It shouldn't take too long, it's just medical overview. You guys, 20-minute break.
This conference will now be recorded.
All right, so let's cover medical overview. So we're going to kind of cover the different topics of the medical assessment, medical scenarios, and then we'll go more in depth over the next few weeks in the medical assessment. And we'll start covering medical assessment as we do our Sunday practicals as well. All right, so let's go over introduction. So patients who need EMS assistance generally have experienced a medical emergency or a trauma emergency or both. Right, so they're inviting us into their world at their most vulnerable time, right? They expect us to come in as professionals and start treating them and diagnosing them and getting them into the hospital. And that's what they're expecting from us. So we need to make sure that we're on our A game every time we walk through the door. So we know the difference between trauma and medical. Emergencies involve injuries resulting from physical forces or a medical condition or illness caused by a disease. So with the medical emergencies, we're going to go over respiratory, cardiovascular, neurologic, gastrointestinal, urologic, endocrine, hematologic, immunologic, toxicologic, psychiatric, and genealogic as well. Or gynecologic, sorry, my goodness, it's getting late. Gynecologic emergencies as well. So each one of these will go more in depth as we cover throughout the next couple of weeks. So with that being said, patient assessment. That's going to be kind of our most important part. So assessment of the medical patient is similar to the assessment of a trauma patient, but with different focuses. So we're going to focus more on the nature of illness, the symptoms that we see, or as soon as they complain to us, the signs that we see, and then the patient's chief complaint, like what is really wrong with them, have them described to you in detail. And this is going to help form our differential diagnosis on how we're going to treat our patients. So information received from dispatch can be helpful in anticipating what you might find when you arrive on scene. However, a lot of times what dispatch tells you is not always what you have when you show up. So tunnel vision may cause you to miss an important injury or illness that you may come in contact with. That's why it's so important to make sure that you're talking to your patient, right? Always have a conversation with them, asking them important questions to help describe them. Let the patient describe how they feel to you, right? And try not to interrupt them as they're speaking. Unless they're going on and on about something that's non-relevant, right? Let them tell you how they feel. Don't interrupt them with a different question. So ensure that the scene is safe. Determine number of patients needing assistance, the nature of illness, and maintain a high index of suspicion, right? Keep in mind, this is the basic of a medical assessment, and then we tailor the medical assessment based on the chief complaint. That's what we're going to cover later on in the other chapters. We're going to form a general impression by identifying the life threats and quickly treating the ABCDEs. So airway, breathing, circulation, disability, and exposure. Also looking at our level of consciousness by utilizing our AVPU scale, alert, verbal, painful, and unresponsive. And keep in mindset that the conditions of many medical patients may not appear serious at first, but they can progressively get worse over time. So you want to remember cause and effect and also understand the pathophysiology about what is going on in that system, our body system that is being affected. So our primary survey is going to cover in the responsive patient, we want to make sure that the airway is patent and open and that they are breathing adequately. So consider applying oxygen if the breathing has been affected. If the patient is unresponsive, you want to make sure that the airway is open using the proper techniques. This could take several seconds to evaluate their breathing. Take the time to see how they are breathing because they could have irregular breathing patterns that could lead to Kussmaul respirations that could lead to what? What would Kussmaul respirations be?
EKA, right?
Yeah, exactly. So look at your patient. Don't just do a quick primary assessment on these patients and blow back the fast that they have Kussmaul, right? That could be a whole different story. Then you get their blood sugar later on in the game. We're going to assess circulation. We're looking for radial pulses. Remember, rule of thumb, radial pulse has a blood pressure of at least 90 systolic. Rule of thumb doesn't mean it has to be accurate, right? Checking the carotid pulse of an unresponsive. Patient's skin, color, and temperature and condition. Quickly glance at the patient to identify any life threats such as severe bleeding or injury to the chest. We can see this kind of stuff. Quick assessments. This is what the primary survey is about, to do a quick assess to see what is really wrong with this patient. Then we do more in detail, tailored assessments based on the chief complaint. Patients who should be considered in serious condition and need of rapid transport include the unresponsive or altered mental status, patients that have airway or breathing problems, or patients with obvious circulation problems such as severe bleeding or signs of shock. These patients need to be a load and go criteria. It doesn't mean load and go and do not treat. It means load the patient, get in the ambulance, start your treatments, and get them to a center that can handle them. Most appropriate. As far as history taking goes, remember, sample, OPQRST, associated symptoms, pertinent negatives. All this information is very important, whether it be asking family members of the altered mental status or asking the patient if they're alert and oriented. Right? Just because a patient doesn't understand where they are doesn't mean that they don't know who they are. Right? They may still be perfectly in control of who they are, what they take, but have no idea of their location. Right? So ask the patient questions. Sample, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading up to the illness or injury. That history is very important, as basic as it is. And we teach this from emergency medical responder, EMR, to paramedic. It's so important to get that detailed history from the patient. The OPQRST mnemonic, right? And then they add the OPQRST-I, which is something that's new, which is onset, provocation, palliation, quality, regional radiation, severity, time, and interventions. So you want to ask follow-up questions. So for chest pain, right? When did it start? What makes it better or worse? Is it sharp, dull, or pressure? What's the scale of 0 to 10, 10 being the worst pain you've ever felt in your life? Where does it rate? How long has it been going on for? Then what interventions we need to do, right? Whether it be listening to lung sounds, to IV therapy, 12 lead EKG, aspirin, nitro. What are we going to go based upon what we find? Ask the patient, are all the complaints, my goodness, ask the patient if they are compliant with their drug regimen, right? Are they taking their drugs or their medications as they're supposed to and throughout the day? Another thing, look around the scene for evidence that may help you determine the history of the patient. You should be able to look at medication bottles and be able to figure out what's truly wrong with your patient as far as medical history goes. If you don't know, that's what Hippocrates is for. Look things up. Right? If they're unresponsive, you want to obtain as much history as you can from family members, friends, bystanders, or even from the scene itself. Unresponsive patient by the refrigerator with a candy bar in hand. What could that potentially be?
Hypoglycemia?
Yeah, hypoglycemia. Simple things, right? Secondary assessment, looking at designed to identify signs and symptoms of the illness or injury and what were not found during a primary survey. This is more detailed stuff. But on the physical exam, we do want to do a full body scan. So we don't know if it's trauma or medical. Always perform a full body scan on your unresponsive patients because they're unable to tell you what's wrong. So we kind of want to figure out what is truly going on there. Obtain a baseline set of vitals. Perform a limited or focused assessment on the chief complaint. They say they have chest pain. Let's not focus on doing a trauma assessment. Let's find out why they have chest pain. Is it reproducible, non-reproducible? Is it sharp, dull, pressure? Obtain a baseline set. Consider using the automatic blood pressure cuff for further assessment at regular intervals after first obtaining your manual reading. Then we can set it for trending and see how this patient is doing based upon our treatments, right? It talks about local protocol considering blood glucose level. We're checking blood glucoses. We're doing end-tidal carbon dioxide monitoring, pulse oximetry, 12 lead EKG. All this stuff is within the AEMT scope of practice to be utilizing for patient assessment. So we're going to go through all of that. And then Brandy will be our paramedic instructor for Sunday. She'll be going over the in-depth medical assessment utilizing all these different tools. So once the assessment and treatments have been completed, you need to reassess your patient. You want to find out if your treatments are working or is the patient getting worse. So reassess vital signs, review all treatments that have been performed, and document everything that's going on. Right? Reconsider the need for paramedic backup. Do you need a paramedic assist? right? Look at all your treatments that have been performed. Make sure that they're all still effective. Do you need to repeat another treatment? Like Duonebs, albuterol. Do you need to go to a second dose because the patient's starting to deteriorate again and pulse oximetries are dropping and the patient's not ventilating appropriately, right? Then alert the ED before on arrival for potentially critical patients. If you have a critical patient, stroke, STEMIs, traumas, have dispatch notify the receiving hospital right away. Give them a 45-minute heads up, half an hour heads up. Let them know when you're on scene still. So that they can start prepping for this sick patient. Okay, especially with your smaller outlying hospitals like where we are up in New Hampshire. Okay, all right. So as far as management and transport destination, most medical emergencies require a level of treatment beyond that availability in the pre-hospital setting. That's why they call us from to the hospital. Right. So administration of medications is limited for an AEMT. However, like in New Hampshire, though, you do have a more higher variety of meds than you would at the national scope. So written protocols may allow you to administer certain medications without calling online medical control. And some medications are med control option. So in New Hampshire, remember correctly, all your medications are standing order. So EMTs can use an AED on a patient who is pulseless and apneic as well. We are utilizing cardiac monitoring also. Your scene time may be longer for medical patients more than for trauma patients, but we really want to shoot for that 20-minute on scene time. But anything more than 20 minutes, a lot of your reporting systems actually flag it and say, hey, why were you on scene longer than 20 minutes? So you have to have a justification on why you were there. Trying to gain IV access, trying to get a second 12 lead, extrication out of the house, but document why you were on scene if you were on scene more than 20 minutes. Critical patients always need rapid transport. Patients with altered mental status, breathing difficulties, circulatory compromise, or patients who are very old or very young. Remember that with kids, they can compensate and compensate and compensate. And then next thing you know, they decompensate to the point where it's hard to keep up. So you want to catch the signs quickly. So types of transport, a life-threatening condition exists. The transportation should include lights and sirens. If the patient is not critical, non-emergent transport, no lights, no sirens, right? So you want to consider where you're going to be going to the hospital. And there are some local access hospitals that we come in contact with that may say, okay, the patient's a trauma, you're at the A level, you can maintain this. I want you to bypass to a trauma facility. So again, depending on where you work, what's going on, maybe to determine where you're going to be transporting to. Modes of transport, obviously you have air medical transport as an availability. For us in this area up here, we have the ability to utilize Life Flight, DART, and Boston MedFlight. So there are different opportunities for us to be utilizing. They also have ground transportation critical care as well, where they send medics and nurses in an ambulance. A lot of your helicopter services carry blood products. So even if you're a paramedic and a patient is trapped in a motor vehicle accident with significant internal bleeding, even calling for flight, even if the hospital is 15 minutes down the road, you get a 45-minute extrication, they can bring blood to you. These patients need blood more than making Kool-Aid with fluids, right? So it doesn't hurt to call. So generally, the closest hospital with an emergency department should be your destination. However, there are certain times where they need to go to the most appropriate, whether that be a cath lab, trauma facility, a neuro facility. But we're not just going to bypass on our own. We need to contact medical direction to find out, hey, this patient's stable. Can we bypass here or not? They may say, no, you have to have a paramedic on board, then you can bypass. All right. Okay, so we try to take the patient to where they want to go. But again, closest facility depending on patient stability. As far as infectious disease goes, it's a medical condition caused by a growth or a spread of a harmful organism within the body. So our general assessment principles would be approach the patient with an infectious disease like you would any other medical patient. Right? Scene size up, ABCs, history taking, OP-Curious TI, elaborate on the patient's chief complaint. Right? If you think it's something infectious and we need to, like a communicable disease, then maybe we need to put on, gowns, masks, eye protection, depending on the type of what we're walking into, like tuberculosis, where we need like an N95, or COVID, where we should be wearing N95 masks or some kind of closed system like that to prevent any kind of infection getting into the airway. All right. Some general management principles, obviously focus on life-threatening conditions first. Be empathetic with the patient and place the patient in a position of comfort on the stretcher. We want to make sure we're keeping them warm, right? Blanket, keep them warm. If you may have trauma patients, you got to expose them, or female patients you're doing 12 leads on, we have to lift up their breasts and things like that to be able to put electrodes on. Try to keep a blanket over them the best you can to keep their dignity. Be professional. Always follow your agency's exposure control plan in cleaning equipment and properly discard any disposable supplies as well as linens. Right? Please do not keep the same linen on the stretcher from the previous patient. Decon your stretcher, decon your ambulance, clean. So epidemic and pandemic considerations. So new cases of a disease in a human population substantially exceed the number of expected based on recent experience. That's your epidemic. The pandemic is an outbreak that occurs on a global scale, COVID-19. Some other HIV infection and AIDS. So human immunodeficiency virus, or it's an infection, and then AIDS as well, first identified in the United States in the 1980s. According to the CDC, prevention, more than 1.2 million people in the United States are infected with this virus. Gay and bisexual men, particularly young African American gay and bisexual men, represent a disproportionate share of new diagnoses. Remember that this is a blood-borne disease and can be transmitted from a pregnant woman to her infant in the birthing process. Also transmitted through blood transfusion, which is uncommon now that blood is tested, but before, when it wasn't tested, it was passed on. So the entire immune system begins to fail, allowing for life-threatening opportunistic infections to flourish. The patient may show no symptoms at all. Other signs and symptoms would include acute febrile illness, malaise, fatigue, sore throat, swollen spleen and lymph glands, headache, weight loss, and possibly a rash as well. So a patient with AIDS is extremely vulnerable to numerous bacterial, viral, and fungal infections that would not affect a person with an intact immune system. Remember, their white counts are going to be low. They can no longer fight infection. So pre-hospital management for this is really supportive. They don't have a vaccine yet at this point in time. Despite the great progress in drug treatments, AIDS is still fatal. Make sure you're wearing the proper PPE. Remember that they are also immunocompromised. So with that being said, you want to make sure you protect them. So put a mask on them as well, right? Remember, you're bringing them in the back of an ambulance. I can tell you right now, flat out, that our ambulances are not 100% clean, right? So we want to make sure that we take care of that appropriately. So it is not easily transmitted in the EMS work setting, but your risk of infection is limited to exposure to be infected by the patient's blood and bodily fluids. However, we are doing IVs, okay? So you can get a needle stick as well. So you want to make sure that when you have a needle in hand, that you dispose of it in the sharps container appropriately. You want to make sure that you're covering any wounds, open wounds that you have, or wherever or whenever you are on the job. So if you have like open sores or dry skin that's open on your fingers, put a Band-Aid on it, protect it, and then put your gloves over that. Right? If you think you have an exposure, contact your exposure control officer to seek medical attention. Influenza, the flu is commonly known as the flu, influenza A and B. These are chronic medical those with chronic medical conditions, compromised immune systems. The very young, the very old are particularly susceptible to this and transmitted through direct contact with nasal secretions, aerosolized droplets from coughing, or sneezing by infected people. You have the H1N1 virus, initially identified as a swine flu in 2009, a specific form of influenza. I haven't seen that at all since then. General treatment includes supportive treatments. So you want to make sure that you're wearing proper PPE, frequent hand washing, maintain your vaccinations, wear a HEPA respirator during aerosolized generating product procedures. So what they're saying as well with this is that if you're a patient that has the flu or COVID, and you have to give them a nebulizer, you should be wearing an N95 mask to protect yourself. And for a while, when COVID first came out, they had us doing nebs in the back of the ambulance with the doors open before we started transporting. So hepatitis would be an inflammation, often an infection of the liver. This can be caused by a number of different viruses and toxins. So complications of hepatitis include scarring of the liver, liver cancer, and liver failure. So according to the CDC, hepatitis C accounted for the greatest number of deaths and the highest mortality rate in the US of the 3 types of viral hepatitis. So we can be vaccinated for hepatitis A, hepatitis B. Hepatitis A is usually a voluntary deal. Hepatitis B is required for the service to provide for you at no cost, or you can sign a declination refusing it. Early signs would be loss of appetite, vomiting, fever, fatigue, sore throat, cough, and muscle and joint pain. Some advanced symptoms would be yellowness of the eyes and skin, and right upper quadrant abdominal pain. As you can see in the photo here, you start noticing some of the yellowing of the skin or yellowing of the eyes as well. So management is strictly supportive of this. There's no sure way to tell if the patients are contagious or not. And every Hep B vaccine is highly recommended for this as well. Hepatitis A is transmitted orally or through oral or fecal contamination. Organisms that cause hepatitis B, C, and G are transmitted through vehicles other than food or fluid. Right. Hep B is far more contagious than HIV is, so vaccination with Hep B vaccine is highly recommended for AEMTs or EMS providers as a whole. And you also want to make sure you seek testing after vaccination to determine your immune status. We'll do a titer check as well to make sure that you are still holding the vaccine. Herpes simplex is a common virus strain carried by humans. Most people carrying the virus are asymptomatic. Symptomatic infections cause eruptions of tiny little fluid-filled blisters called vesicles that often appear on the lips or the genitals. Herpes simplex can cause serious illness like pneumonia and meningitis in the very young and the very old, and anybody that's immunocompromised. So anybody has the low white counts for cancer patients, things like that. The primary mode of infection is through close personal contact. So again, wear standard precautions. Syphilis, although syphilis is commonly thought as a sexual or a sexually transmitted disease, it's also a bloodborne disease as well. So there's a small risk for transmission through contaminated needle stick injuries or direct blood-to-blood contact, but the initial infection with syphilis produces a lesion called a cancerous, but also are most commonly located in the genital region. Hi, Jen. Welcome back. So again, we're going over this kind of stuff pretty quickly here. We're going to be touching all this stuff in depth as we go through the different systems of the body. Again, this is more just a brief overview. Meningitis is inflammation of the meningeal coverings of the brain and spinal cord. So we have viral and bacterial meningitis. There's 2 different types. Obviously, our bacterial meningitis is very contagious. Signs and symptoms would include fever, headache, stiff neck, and altered mental status as well, so resulting in that rigidity in the neck. an increased fever. This can be caused by a virus or a bacteria, which are most of which are not contagious.
My son had that when he was 6.
Meningitis.
Yeah, I think it was viral because they said it wasn't contagious, but he was wicked sick. He almost died. He had a temperature of 107.9.
Yeah, that's crazy. We see really sick patients like this. We don't see a ton of meningitis cases, at least not up where we are, but you get more to the cities, I've noticed obviously a higher population.
They actually think that it was originated, they called it Lyme meningitis because they think that he had been bitten by a Lyme tick and had Lyme disease that like evolved somehow into meningitis before it was detected.
Interesting. So vaccines are available for most types of meningococcus as well. So treat it as an emergency department with antibiotics. Again, though, gloves, masks go a long way to prevent the patient's secretions from getting into your nose or mouth, prevent that from happening. After treating a patient with meningitis, contact your employer and health representative. As in many states, meningitis is reportable. In such states, you will be contacted if one of your patients is diagnosed with meningitis. Tuberculosis is a chronic microbacterial disease that usually strikes the lungs. Many infected patients are well most of the time. However, the disease involves the brain or kidneys. The patient is only slightly contagious. We should be doing yearly tests with this. We do a TB test where they place a droplet under the skin, more like a subcutaneous injection. And then within 48 hours, you're supposed to go back and have it read. And if it's blotchy and spreading with a ring, that usually means that you've been in contact with tuberculosis. Then they'll send you for an X-ray, chest X-ray, to see if you actually have it. It's a good test to have. Maine actually requires it for EMS services once a year as well. So N95 type of masks are required to prevent the inhalation of the droplet nuclei that you can come in contact with. There is no absolute protection from the infection. With the tuberculosis does not exist. Everyone who breathes is at risk, doesn't matter who you are. So according to the WHO, 1/4 of the world's population is infected with tuberculosis. The vaccine for tuberculosis called Camlet-Guerin. It's only rarely used in the United States. Again, the mechanism of transmission used by the M tuberculosis is not very efficient. So the preventative therapy is almost 100% effective. It's there. A lot of times you'll see this in more third world countries as well. Pertussis, also called whooping cough, is an airborne disease caused by bacteria that previously affected children younger than 6, now becoming common in adults whose vaccinations were years prior and whose immunity has decreased. So now we're starting to see it more in the adults. So the best way to prevent the infection from pertussis is to be vaccinated with what they call the DTaP, diphtheria, tetanus, and a cellular pertussis vaccine. So the DTaP. For added protection, mask on the patients and protect yourself. Right, MRSA is a bacterium that causes infections and resistant to most antibiotics. So we see a lot of this, like nursing home patients who have MRSA, the respiratory MRSA to a wound MRSA. The best way to do this to protect yourself is find out where the MRSA is. Is it still currently active and spreading or not? And use gloves and practice good hand washing to protect yourself. Right. So please don't go licking the wounds or anything else because that'll just get more sick. Right. Good hand washing. Factors that increase the risk for developing MRSA include antibiotic therapy, prolonged hospital stays, a stay in the intensive care or burn unit, exposure to infected patients. Incubation period for MRSA appears to be 5 and 45 days. So remember, that can live on the surface of your ambulance. That's why it's so important to decon everything with your correct wipes. All right. So new and emerging diseases, the hantavirus, which is rare but deadly virus transmitted through rodent urine and droppings. It's not transmitted from person to person directly, but a vehicle, but by a vehicle, such as food, or a vector, such as rodents. The West Nile virus, which is a vector, is a mosquito, which affects humans and birds. Not communicable and pose no risk during patient care at all. Almost done. So the SARS, something that we check all the time when we worked in the emergency department. We do something called a fourplex test, which would do flu A, flu B, COVID, and RSV, which is a little bit different, but not SARS. But we do those different types of checks, looking for but severe acute respiratory syndrome, SARS, is a severe, potentially life-threatening viral infection caused by a recently discovered family of viruses. So usually starts like flu-like symptoms, which may progress to pneumonia, respiratory failure, and in some cases death. This is transmitted by close person-to-person contact or secretions. So again, if we think SARS is there, we need to make sure we're wearing appropriate PPE. So I always carry an Envo with me on calls, just in case I have a patient that has something respiratory that I might have to put an Envo on to protect myself. So the avian flu, or the bird flu, is caused by a virus, H1N1, that occurs naturally in the bird population and carried in the intestinal tract of wild birds, and does not usually cause illness. In the domestic bird population, chickens, ducks, and turkeys, it is very contagious. And if an affected bird is used for food or is cooked, it poses no risk to whoever eats it. Humans can get it when they have close contact with infected birds, but there's no rapid human-to-human cases that have been reported, and the transmission risk for humans is very low. As far as the global health issue, the Middle East respiratory syndrome coronavirus, I think we've heard enough of that over the few years here. So most commonly found in bats and camels living in the Middle East. Symptoms include high fever, cough, muscle aches, vomiting, and diarrhea. Presently, there's no cure or vaccine for this virus. So it's the MERS COVID. Place a surgical mask on the patient and notify the receiving facility that you have that. Now we have the COVID-19, which was first reported in Wuhan, China, on December 31st, 2019. And we all know about COVID-19. I don't think I need to go. You guys want me to go in depth on COVID, or are we pretty much done with it? I'm going to guess with no response that we're good. Over it, done. We've heard so much of that. Again, COVID's never going to go away. Never going to go away. There's going to be different strains, just like the flu. Your choice if you want to be vaccinated or not. Again, if you have respiratory patients, protect yourself. That's all I can say. Wear N95s, wear your surgical mask, whatever you choose to do, protect yourself, okay? Don't bring it home. I can tell you over time, when they first came out, we saw a patient intubated, people were dying from it. That strand I have not seen in a while. And we're seeing patients with COVID that just run its course. Some go to the hospital, some don't, and we move forward. Ebola, I can tell you that I remember when this was a big scare when it first came out. Incubation period was approximately 6 to 12 days after exposure. Symptoms may not begin to appear for as long as 21 days after the infection. Ebola was first, I believe, it was first found in the U.S. in Texas. I know it came over, but again, Ebola didn't last long over here. It was pretty much stopped. It was stopped pretty quickly. I remember putting Ebola suits on the ambulances. I mean, it was a big scare. We had to have all this stuff, and then it kind of just went away. The Zika virus was a vector-borne infection transmitted by mosquito bite. There is no vaccine yet. Symptoms include fever, rash, joint pain, and conjunctivitis. And most significant complication of Zika virus affects pregnant women. Other symptoms may include muscle pain and or headache. and symptoms usually are mild and last several days to a week. And 1 second. All right. And it can be diagnosed with a urine or a blood test. As far as travel medicine goes, losing my voice here. Patients who acquire an illness from another country can present with a variety of symptoms depending on an illness. So when you encounter an ill patient with a recent travel history, place a mask on the patient and gather as much information as possible. I can tell you that I was fairly sick when I came back from Athens, and I had a respiratory thing that lasted about 2 months with fevers every day. It probably was COVID, but this is back in like October of 2019. It was not fun by any means. So that's something that I was over after about 2 months of that. Some important questions, obviously, to ask would be, where did you recently travel? Did you receive any vaccinations? Were you exposed to any infectious disease? If there is anyone else in your travel party, who else is sick? What types of food did you eat? What was your source of drinking water? These are all questions you want to ask these patients, excuse me, to help determine some of your treatments, and also things that you need to as well pass along to the hospital. So to conclude all this here, the assessment and treatment of medical patients can be very challenging. Patient's medical condition may not be as readily apparent as in a trauma patient. Again, everything we do is tailored around the chief complaint, but we have to go more in depth as ALS providers, right? More in depth as ALS providers to get the information we're looking for to come up with a proper treatment plan. So the best approach is keep calm, use your patient assessment skills, right? You know what I expect from you, right? For those, we all did assessment last class for trauma, right? I expect the same thing for medical. Understand the pathophysiology behind stuff, why you're doing what you're doing, there's a cause and effect, and how do we treat? Differential diagnosis. Treat the patient's symptoms while maintaining a high index of suspicion. Report to medical control. They are your friend. Call them. They are there to consult if you don't know what's going on. I've done it myself, saying, I have no idea what's wrong with this patient. I'm going to call a doctor and find out. Maybe they know. And consult with them. Transport the patient safely to the closest, most appropriate facility. Trauma centers, stroke centers, right? Follow your local protocol. And keep in mind that patients sometimes have more than one isolated problem, right? They may have one, and then once you reduce one of them, another symptom may appear, and you got to treat that. Cause and effect. All right.